my name is Tim Pawlik. I'd like to talk to you about our paper entitled Impact of Academic Medical Centers on Surgical Outcomes of Neighboring Non-Academic Medical Centers. To date, the broader impact of academic medical centers on regional patient care has not been well understood. Surgical care is inherently complex, and perioperative outcomes may vary across AMC versus non-AMCs. In particular, the geographic variation in AMCs across the United States and the impact on neighboring non-AMCs among patients undergoing complex surgical procedures has not been investigated. Therefore, the objective of the current study was to assess the geographic variation in academic medical centers, as well as to evaluate the impact of academic medical centers on postoperative complications, readmission, and mortality following major surgical procedures performed nearby non-AMCs. The Medicare Standard Analytic File were queried using ICD-10 codes to obtain data on patients aged 65 years or older who underwent surgery between 2016 and 21. The primary exposure was the presence of an AMC in the healthcare market. Healthcare markets were defined using the Dartmouth Atlas Hospital referral regions. The primary outcomes were postoperative complications, extended length of stay, and 90-day mortality. Among the roughly 390,000 patients, 1 in 4 underwent a CABG, and about 1/2 had a colectomy, while other procedures were less common. A total of 3,756 hospitals across 306 healthcare markets were included in the analytic cohort. 3/4 of hospitals were non-AMCs. The median number of AMCs per hospital market was 2, and the distribution of academic medical centers varied considerably across markets and the country. In particular, 82 markets had a low AMC, while 91 markets had a high AMC. Overall, only about 45% of patients underwent surgery in a market with a low AMC presence, while about 1/2 of patients had surgery in a hospital with a market that had a moderate AMC presence. So in total, only about 1 in 10 patients had surgery in a market with a high AMC presence. Of note, patients who underwent a surgical procedure at a healthcare center that was located in a high AMC market were less likely to experience a postoperative complication, have an extended length of stay, or die within that indexed hospitalization related to the surgical procedure. Moreover, patients were more likely to be discharged home and were less likely to be readmitted if they had their surgery performed in a non-AMC hospital, but one that was located in a high AMC market. In addition, the cost of each surgical episode was $10,000 more expensive in a non-AMC hospital if that hospital was located in a low AMC market. In summary, there was significant geographic variation in academic medical centers across the United States, with the predominance of AMCs in the Northeast and Midwest regions. Moreover, a high AMC presence within a market was associated with a decrease in extended length of stay, complications, 90-day readmissions, as well as 90-day mortality and costs. In conclusion, the data suggests that AMCs had a spillover effect on surgical outcomes of neighboring non-academic medical centers, indicating that the benefits of academic medical centers may be far broader in the community than has traditionally been recognized.